now proceed to the World Medical Association session. This session focuses on the duties and rights of health professionals during a pandemic. We now invite the following participants to the stage. Professor Rui Nunes, President of the World Conference on Bioethics, will be the chair of the session. We also invite to the stage our two distinguished speakers. Dr. Otmar Kloiber, Secretary General of the World Medical Association, who will present on the Hippocratic, hot and modern medical deontology, interpretations and misunderstandings. And Dr. Annabel Seebohm, CEO of the Standing Committee of European Doctors, who will discuss the health professions, the society, and the state, expectations, obligations, promise, and realities. And Dr. Rosylane Rocha, Vice President of the Federal Council of Medicine, will present on physicians and medical ethics. We now invite Professor Rui Nunes to begin the session.
Well, good afternoon to all of you. Again, it is an enormous pleasure to be here in this panel of the World Medical Association. As we all know, the World Medical Association is a partner in this event, in this World Conference, as it is in the last years. So thank you very much, Dr. Otmar Kloiber, and also to Dr. Lujain Al-Kodmani, President of WMA, for this long-standing partnership. We are going to initiate this panel, and I'm going to give the floor to Dr. Otmar Kloiber, that is going to make a presentation on the Hippocratic Oath and modern medical deontology, interpretations and misunderstandings. Thank you very much, Dr. Otmar Kloiber. You have the floor.
This one. Okay. Thank you, Rui. Ladies and gentlemen, distinguished guests. During the COVID-19 pandemic, a lot of our colleagues, be they nurses, pharmacists, doctors, have worked under deep distress, and many of them have turned out to be real heroes, at least in my opinion. They have worked under situations which were very severe, extremely dangerous, and the World Health Organization has concluded that probably more than 150,000 of the health personnel have died during the pandemic. And I guess each of us who is in one of those professions knows somebody who has died, and some even several of those who have lost their lives during the pandemic. Yet during the pandemic, very often the image came up that without condition, health professionals have to serve and have to treat. Many have done, as I said. And nevertheless, the question then should have arisen, what are obligations and rights of health professionals? I'm not sure whether we can show our slides, that would be kind, which we have prepared for this session, and how we can proceed them. Is that possible, to have the slides projected for this presentation? Wonderful. Thank you very much. Is there a possibility that I can advance them myself, or how can I steer those? So already during the pandemic, Andreas Reis, who is co-chairing the ethics department at World Health Organization, approached us and said, well, we have to think about the ethics of the pandemics and what it does. And he asked Annabel and myself to come up with a chapter on the duties and rights of health professionals. And that is what we will be speaking about here, hopefully in a way that you see some controversy and some problems, and maybe we can have a discussion after that about our conclusions, how we see the rights and duties of health professions, and how that relates also to the rights of the patients. Both of us, we don't have to declare any conflict of interest, at least to the best of our knowledge, and certainly no financial interest with that. And here you see also Annabel's affiliations, which she has had and which she currently has. In the outline, I have to stress a little bit the fact that we have started this work when we wrote this book, or our chapter of this book. We started this from a European perspective, actually from a German perspective. Both we are from Germany, but we later have extended this to a more global perspective. And whenever we are discussing ethical questions in modern medicine, in school medicine, yes, we are very much Eurocentric. That still is a fact. And a lot of what we have as philosophy behind medicine has derived from this environment in Europe, coming to the modern medicine in most parts of the world. That does not mean that we do not acknowledge that, well, there has been ethical development and ethical guidance and principles in other parts of the world. But looking for the school medicine and what has shaped our profession, the profession of, for instance, nurses, the profession of physicians, that very much has a background that was grown in the European sphere. And that certainly is reflected in this presentation, so I beg your pardon for that. I will first speak a little bit about the Hippocratic Oath, because when we were in the pandemic and when it came to the question what physicians have to do, this was always stressed, that there is a Hippocratic Oath and that physicians have sworn the Hippocratic Oath, a notion that we have heard from the press very often. And I think I have to debunk this myth a little bit and talk about it. I would like to speak not only about, or we would like not only to speak about the duties and rights of the physician, but also put them in perspective of what patients have to expect and what their rights are, because I think that is important to understand, that this is something that has to be seen from two sides in a reality there. And Annabel will put this into a legal context, and also we will try to put this into a deontological context from the side of the physician organizations. And to that, I certainly would like to rely on the work that has been done with the World Medical Association, as we as a physician organization have shaped the physician deontology quite a bit for the last century. Now, let me start with the myth of the Hippocratic Oath. The original Hippocratic Oath is actually no good for physicians nowadays. It obliges physicians to Greek gods, to swear to Greek gods. It prohibits surgical interventions, you probably all know. It requires avoidance of potentially deadly interventions, no risky things to be done. And looking at it on a sober position, it's probably mere a competition regulation than an ethical or moral code at that time. And even more important, most likely, hardly any modern physician has indeed sworn the original Hippocratic Oath. That is a myth that is persistent in the public notion, in the press, when it's spoken about ethics of medicine, that people believe that doctors would swear the Hippocratic Oath. Some of us may have been confronted with a modernized version of somebody who has made it, but indeed the original Hippocratic Oath, I hope none of the physicians has really sworn. So the Hippocratic Oath does not really connect with an image of humanity and empathy, what we have seen and what we have been seen living also during the pandemic by many of the health professions who have worked so hard. For the European culture, it is very clear that there has been a shaping for the last 2,000 years of the image of medicine by Christian principles. And there's two important are Caritas and Misericordia, which translate into the English of the care and the compassion and mercy, something that for us are guiding images of medicine. And the physician profession and also the other health professions, especially physicians and pharmacists, have shaped very clear in the translation of the medieval Arabic medicine into the modern medicine, which has taken part in the early Middle Age, especially in Southern European universities. And caring and nursing have become the core virtues of Christianity, and it's by no chance that the Catholic Church is still the biggest healthcare provider on this earth. So they provide most of the healthcare facilities and services, and that is not by accident. But let's also have a look on the other side on health and human rights. And I will focus a little bit on the international law situation here of what states have said they believe is health and human rights. Very important, it turns out shows up in the Constitution of the World Health Organization 2 years before it actually was installed in 1946. And there is the enjoyment of the highest attainable standards of health as a principle in this Constitution. But it doesn't say how that should work. It gives it as just a phrase, which is there, but it doesn't say who should do what, how should that be realized. It gets a little bit more clearer and repeated in the Universal Declaration of Human Rights, 1948, but still without saying who should do what. And then it gets very clear in the Covenant of the Economic, Social, and Cultural Rights in 1966, when special items of healthcare are listed, namely here industrial hygienes, occupational health, but also maternity care. Excuse me. And here it becomes clear state function. And this gets even clearer in the commentary to this article from the year 2000. Now, we are now half a century on already, and very close to our time, when it said states have the obligation to provide healthcare. States have the obligation to provide healthcare. And that is very important to keep in mind, that the governments themselves have declared we are obliged to provide healthcare. Now, is that something they have lived up to? Is that what we, as citizens, have received from the states? Is that what, as rights and protections for the health workforce, the health personnel have received? And looking on the pandemic and what we have seen in the years 2020 and 21, I'm sorry, I must say most of the states have failed. Neither have the states provided universal health coverage to most of the people on this planet. There are some countries which are doing better than others, no doubt, but really universal health coverage is still a very rare phenomenon on this planet. Nor have they taken preventive measures. Yes, I admit, there are countries, especially in Southeast Asia, with the background of SARS and MERS, have done much better than others. But the pandemic preparation in many of the countries, including my own, in Germany and the countries around Germany where we both are living, have been more a joke than anything else. There was no real preparation for pandemic, no protection, no strategic, no legal preparation to deal with such a situation. But yet, and this is important, it leads over to the second part, which now Annabel is taking, yet there was always a projection by politicians, by the public, that the health professions have to serve and have to deal and solve the project. Yes, there was applause in the beginning, and there were a lot of promises, but it was the health professions, the health professionals who had to deal with the crisis. Annabel.
Thank you very much. So you said, Otmar, yes? Warte mal, jetzt muss ich hier zurückgehen. How do I do this? Oh. Sorry. Gott, was ist denn das? Oh. The question is whether this objection is actually justified. And I can reply, and again, I'm coming also from the German background as Otmar does, and a bit of the European background. There is no such obligation to treat. There is no such, so the projection is unjustified. There is no general obligation to treat unless there is a treatment contract in place between a patient and a physician or a nurse, or there is a specific status the health professional is in, such as a contracted status in outpatient care, for instance, or being employed by a hospital. And this status sort of obliges me to serve certain obligations. However, there is no general obligation to treat. What exists, though, in many civil law countries is a general obligation to render assistance in emergency situations, in an accident, or common danger. However, and for instance in Germany, this general obligation to render assistance is sanctioned by criminal law. So if you don't follow this general obligation to render assistance in an emergency or accident, you may be punished by criminal law. However, this duty is not unlimited. It is limited to doing what is reasonable, and a helper does not have to substantially endanger themselves. Now, you need to know, for health professions in Germany, for instance, they're even free to refuse treatment unless the two exceptions apply, which I just explained in the top of the slide. So you need to assess in every single individual case and ask the question, was medical assistance actually necessary and reasonable in the specific individual case? In common law countries, this is different. Generally, in common law countries, there is no general duty to rescue. A person cannot be held liable for doing nothing while another person is in peril. Looking at the United Kingdom, for instance, for health professions, a doctor must offer help if an emergency arises. This is what the General Medical Council prescribes in its Good Medical Practice Guide from 2013 and 2024. However, despite this professional duty, it does not exist as a legal duty. Therefore, a doctor would not be held negligent for failing to offer help outside of their clinical setting. In Australia, though, this seems to be unclear. They are currently discussing whether there is a legally enforceable duty for medical practitioners to render such assistance. So to sum up, there are, not strictly speaking, obligations except the one in civil law countries, but there are huge expectations vis-à-vis health professions, and they are more demanding given their legal and or ethical duties to rescue in virtue of their roles. Yet the obligation to care is projected on health professionals, mainly doctors and nurses. The question arises, when we move to pandemics, the situation of a pandemic, are there things such as compulsory obligations which exist? Again, coming from Germany, we looked at what was happening in Germany. The German Basic Law and the Federal Infection Protection Act does not foresee any compulsory obligation towards individuals to provide healthcare. There is no such thing as a compulsory obligation. But, as in Brazil, in Germany we have 16 states, so-called Länder. 4 of them tried. That was Bavaria, North Rhine-Westphalia, Lower Saxony, and the city of Bremen. They tried to introduce a state infection protection act forcing nurses and health and doctors to serve in the pandemic and to treat. However, this attempt failed. This attempt failed because it was unclear whether there are legal grounds, because the federal level may have been competent and not the state level. But more importantly, also the public outcry was huge, given one specific group was obliged, but not others, leading to the question of, is it maybe general civil conscription you need to look into? Because generally, civil conscription exists in many countries, but these apply to all civilians and not to individuals. Civil conscription is the obligation of civilians to perform mandatory labor for the government. And civil conscription, strictly speaking, is an exception of the Forced Labor Convention of the International Labour Organization. That is, in times of extraordinary events such as also pandemics, a civil duty may arise and may be established to perform the tasks deemed necessary for a limited time. Leading to the question, are there professional obligations for doctors and nurses? And we do have a historical development of professional ethics in medicine and nursing. It starts with the professional self-understanding and goes to the codification of professional ethics. And this is where Otmar will delve into in a second again. And it resulted in also legally binding professional, rather administrative codes. However, generally such ethical and legal codes do not contain strict obligations to act, but they may contain powerful self-commitments. And we will look at now examples from the World Medical Association codes in how far they oblige anyone to treat. Otmar, over to you.
Thank you. So, from a legal point of view, there are very, very limited obligations to treat for a doctor. The idea is that every doctor has to see every patient who is coming to him is actually legally not backed, neither in the Roman law system nor in the civil law system. And even in times of emergency, it is also limited, and limited in the Roman law systems not to endanger yourself, and very weak in the common law system. So now people may understand, okay, there is not the Hippocratic Oath, there is no legal background. What do our duties, our deontology say, our codes and policies which we have? And for those, I certainly will try to work along the papers of the World Medical Association's the Declaration of Geneva, the Physician's Pledge, which was made 1948 purposefully to replace the Hippocratic Oath, because it was believed that the Hippocratic Oath was not suitable for the modern times. And it has a very clear dedication for protecting and caring for patients. It values lives and medical secrecy. It has to avoid harm whenever possible and to exercise with the profession in conscience. In 2017, there was a first big major modernization of the Declaration of Geneva. And with that, the new Declaration of Geneva, the new Physician Pledge, puts a very strong focus on patient autonomy. Not that the World Medical Association has not reflected on patient autonomy the years before, but it had not been verbatim within the Declaration of Geneva. And then other ideas came in which are important, which I will skip here because they are not that important for our topic. But one point is important with the Declaration of Geneva, is that for the first time there came a passage in which says, you also have to care for yourself. You have to care for your own well-being, and that is a promise which we take from you. Why is it important? Because only if doctors, and the same is true for nurses and for other health professionals, if they are healthy, competent, and fit, they can serve their patients. Otherwise, it is not possible. But there is no unlimited demand for care, to give care, in the Declaration of Geneva. The Declaration of Geneva was completed or was complemented 1 year later by the International Code of Medical Ethics, which is the core deontological document for physicians globally. And again, in a revision which we have done, not in 2012 as it says here, in 2022, patient autonomy played a stronger role, equity and justice, physician well-being, what we have just discussed with the Declaration of Geneva, and some other points. But again, and this is important for us here, except for the time of emergency, it does not give a general obligation to treat. And the one for the emergency also is extremely restricted. Now, as I said, there is a general idea of a physician serving individual patients and the community. We are not standing alone. We respect that we have to serve a community, a society as such, but that does not mean that there is an immediately obligation resulting from this relationship. And more important, coming to the emergency, the International Code of Medical Ethics says physicians should provide help in medical emergencies while considering the physician's own safety and competence and the availability of other options for care. And that reflects very much the command by the Roman law systems, which have a similar idea about the obligation to provide help. Although the Roman law applies this to everybody, not only for physicians, it applies this rule to everybody. And here you find it as the only point in the physician deontology where it says you have to deliver help if nobody other can do that and if you don't endanger yourself. And back to you, Annabel.
Now, having looked at the obligations, the ethical and legal background of obligations of health professions, in particular doctors, we also looked at professional rights, because when you have obligations, you also have rights. And one aspect of the professional rights is occupational safety. Now, in the European Union, generally, workers have a right to occupational safety and health, and that is the prevention of accidents, no exposure to hazardous substances, and of course you need to have compensation systems in place that cover treatment or compensate incapacity to work or death. Here the employers generally have to prevent ill health at work. They have to take appropriate measures to make work safer and healthier, and they need to conduct risk assessment and training regularly. Pending that risk assessment, protective and preventive measures may be very high, meaning these measures differ qualitatively and quantitatively from normal operations to operations in a pandemic. However, be you in normal operations or be you in a pandemic, whatever the safety instruction is, they do not change simply because you're lacking supplies. Supplies, for instance, in personal protective equipment. This is really an important principle. Safety instructions do not change simply because you're running short. And to avoid these shortages, and we have seen these shortages at the time of COVID-19, we need to move away from this just-in-time approach to a just-in-case approach. During the past decades, many governments have given up on a just-in-case approach and went to a just-in-time approach, leading to the catastrophes we went into. Now, having lessons learned from the crisis we were in, the European Union is working on a dedicated structure to do exactly that, to, for instance, set up strategic stockpiling for masks, gloves, medicines, other medical countermeasures, and the World Health Organization is working on a pandemic treaty to also look into response mechanisms. specifically the rights, when it was about COVID-19, the question was, is this actually an occupational disease? And again, in the European Union, it is considered an occupational disease. I cannot generally say that because the European Commission is not legally competent for doing that, but they could recommend that, and they did so in 2022, telling the member states, recommending to them to recognize COVID-19 as an occupational disease if contracted by workers in the activity of disease prevention, health and social care, domiciliary assistance, or during a pandemic in other sectors where there is an outbreak and where a risk of infection has been proven. Now, this has been encouraged to be established all over the European Union, and however, and I think it's been established in most of the member states of the European Union, however, of course, compensation schemes differ. So, I mentioned this in the very beginning, there is no general obligation to treat unless, and then I listed the exceptions. So there is even a refusal to treat. I said there is no general obligation to treat unless it is about an emergency assistance, and in civil law countries this is even sanctioned by criminal law, at least in Germany, or provided by contract employment status. The treatment requires a treatment contract both parties agree to. Health professions, however, can even refuse entering such a treatment contract, even without giving grounds, unless the exceptions apply. In the specific case of conscientious objection, any doctor, regardless the status he or she is in, can refuse to treat for moral reasons. However, it's important to note, conscientious objection has limits. Again, if it's about endangering lives of patients or refusal of medically necessary treatment, because then here, again, it's about emergency assistance, which, at least in civil law countries, is an obligation, or ethically it's an obligation and required to treat and provide assistance. However, not even a contracted or employed physician can be forced to put themselves into danger. That's the limit of emergency assistance. And such a danger may also be present if patients with potentially life-threatening pathogens are to be treated without the availability of adequate protective measures. We wish to sum up in conclusions what we have been describing in our chapter, and I hand over to Otmar again to conclude.
Thank you very much. So what we have seen is health professionals have duties derived from general moral principles, from general law, from professional codes, and from contractual relationships. But those are usually defined and bound and related to established patient-physician relationships, so contacts which are already there. An obligation to treat beyond established relationships is described for emergencies, as we have heard, and certainly one can call a pandemic an emergency. Yet, the obligations are not absolute. Nobody has to put him or herself into danger. That is a common understanding as well in the law as in the deontology. So, there must be a claim by the states, or if there are claims by the states vis-à-vis one profession only or one group of profession only, the question arises, is this compatible with the principle of equality, of equality, because it only points to one group in a population, and I think it is not. So states may have contractual relationship with doctors, for instance, in a state-run healthcare system, by contracts that have been made, and those may allow the states to demand the work of a physician even in a specific situation of an emergency. However, that must be balanced by a proper preparation by the states for this emergency, for this preparation, see covenant, which we have just quoted, which governments themselves have promised. And there must be enough resources in order to protect those who are working with patients and in danger in order to protect themselves. And that includes, of course, PPE. That includes, of course, vaccination if available and as soon as available. But it also requires that the state has to prepare its legal apparatus in order to be able to deal with a pandemic. So we must know before what the state can do and has to do in a time of pandemic. And most of that, unfortunately, had not been done. What we are asking for, and let me finalize with that sentence, what we are asking for now, also in this discussion of a pandemic treaty, is that the states are better prepared if something like this pandemic occurs again. And that does not only mean that they have an idea of calling doctors to help, but also that the necessary protections are in place, that there is enough staff, that there is enough PPE, that there are vaccinations available if they can be given to protect the health professionals. And what we also say is, it is unfair and certainly not compatible with the principle of equality to call just one group of society. If there are conscriptions and if there are measures that have to be taken, they have to apply to all and not only to one group. Thank you very much.
Thank you very much, Otmar, Annabel. Excellent presentation from a medical, ethical, and legal perspective. It is a complex issue because we usually teach our students they have this mandatory obligation to treat patients, but nevertheless, I think it was an excellent perspective that should be nonetheless more promoted before another pandemic does arrive. Now I'm going to give the floor to Dr. Rosylane Rocha, that is Vice President of Federal Council of Medicine, to make a brief comment.
Okay. Hi, everyone. Thank you for coming. So your presence here brought even more brightness to the 16th conference. It's an honor for me to share this panel with Professor Rui Nunes, Dr. Annabel, and Dr. Otmar. I made some notes here, and I want to do two questions. There is a real concern about the attempt to control medical autonomy, and economic and political group try every time to limit free professional exercise. So, medical autonomy, but be limited and ethics and law within the bioethical principle of beneficence and no maleficence. In adverse situations and without scientific consensus, for instance, is a medical decision with shared responsibility with the patient, a recommended ethical and bioethical conduct, Dr. Annabel. Sharing responsibility and respecting the patient autonomy and also the the physician autonomy. Is it recommended conduct when there is no scientific consensus in the example of the pandemic?
May I ask that?
Yes,
question?
please.
I think that comes directly to the role of the deontology and the seriousness of the physician work. Both the International Code of Medical Ethics as the Declaration of Geneva require the physician to exercise his profession according to scientific standards and with conscience. So what we have seen, unfortunately, during the pandemic, that there were some spooky ideas about healthcare, or even some doctors trying to sell remedies which they have invented. This all is clearly violating our ethical standards and the deontology. I think there is no doubt about that. And it is something which we have spoken out against during the pandemic very clearly. And it is also important that there is no right to just have a kind of a wildcat experimentation with patients during that time. So when experiments are being started, then this indeed should be done according to our general ethical rules and standards, and especially the Declaration of Geneva, of Helsinki, which regulates then the process for experimentation.
Good. In this time of technological evolution, robotization, and remote interpersonal relationships, telemedicine is advancing, replacing in-person contact, and the humanization aspects of medical care. So, within the concepts of non-maleficence, remote assistance as frequent replacement for in-person care with the patient can lead to errors, mistakes, and cause harm to patients. What are the recommendations to the physicians?
Thank you. Yes, this is a topic that has changed quite a bit over time. A couple of years ago, we would have said medical care is extremely personal. It requires a direct contact between the physician and the patient, and it cannot be replaced by telemedicine. However, things have changed. While we still believe that the gold standard is the direct eye-to-eye and physical contact between patient and physician, and there's no doubt about that this is the gold standard, there are situations where clearly telemedicine can help. Number one, we have found that there are especially mental illnesses which allow the contact or seeking help from physicians easier when it can be done remotely. So even initial contact sometimes can be helpful and reasonably being done remotely in certain cases. With a lot of problems, I would agree, but there are good studies which show that there is a reason to allow initial contacts in certain cases and certain circumstances, especially with mental diseases or emergencies. And with the pandemic, we have seen a completely new wave, especially in primary care, that doctors were happy not to have too many people in their waiting room, but that they could do certain things via telemedicine and teleconsultation. Like, for instance, repeating prescriptions, like for giving recommendations in minor situations, like following up of care where it was not necessarily to touch on with your hand to examine in person. So there are a lot of things which go on. And I think what we will see is with wearables, with a lot of gadgets which we can get and will get in the future, that there will be more and more advice that can be given, and treatment actually that can be given remotely. So we have, as the Conselho, as the Council, as the chambers and orders, we constantly have to look into the options of telemedicine, and we have to see what we have to allow or even to recommend to do, and we have to look into the situations which we should avoid and where we should not mistreat patients by not seeing them in person.
Okay, thank you. No further comments.
We now invite Dr. Ramin Parsa-Parsi to the stage to close this session.
Thank you very much, and thank you for this very interesting presentation, both Otmar and Annabel. And I have to say, I completely agree with you. I would support 100%, but for the closing, let me challenge you a little bit on some of these aspects. I guess when we think about healthcare professionals, physicians, for example, I'm a physician myself, so I'm speaking on behalf of myself. I guess physicians are specifically skilled to provide aid in emergency situations. And we could understand that there is sort of a social contract between healthcare professionals, between physicians and the society. What do you think would be the impact on the patient-physician relationship, the patient-physician trust, the trust of patients to physicians, when physicians opt out in such a situation?
Sorry, Ramin, but I have to directly respond. I hope I made it clear that at least in civil law countries, if there is an emergency, physicians have to act. Yeah, they don't have to put themselves into danger. Their help should be reasonable according to the situation. And if they're medically skilled, they're even more asked to provide help. So in emergency, it's an exception from the general obligation. There is no general obligation except there is an emergency.
I understand that, and thank you for responding immediately, but I'm talking specifically about these emergency situations. And I guess even in those kind of situations, physicians would have the option to opt out if their own life is at risk, for example. And if that happens, and there's also the question about the fairness between physicians and their colleagues, if some colleagues opt out and others continue with their aid, what would be the effect, first of all, between physicians and also on the trust of patients and physicians?
Very, very good question, Ramin. First of all, I think it is at the point right now hypothetical, because what we have seen is a very strong engagement of all of our colleagues. And the calls or the demands for dropping out were very, very few. So negligible, not a problem. My perspective is rather a perspective of what happens in the future. What are the learnings of this? And at that point, we are very, very poor. Especially our governments are very poor, because I don't see preparation for the next pandemic. The next pandemic will come, or the next big emergency. It will come. I see an international community at the Geneva level, which is now for discussing for years for a pandemic treaty, and is getting nowhere. That is a poor outcome. And we, as well the patients and the health professionals, we are paying the price for this. And I think this is something where we have to demand from our governments to do more, to go for better protection, to have better workforce, to have surmountable workforce loads for the nurses, you know, which are overworked in most parts of the world because they are not enough. There is not enough protection. All the things which we have seen in the pandemic, to have masks on stock, to have PPE on stock, all of this is gone already again. You know, we are back to normal before the pandemic, as if the pandemic has not happened. Yes, The European Union tries HERA, this agency, to prepare for this. Let's see what they do if it happens. But when it comes to our national governments, most of them, I'm sorry, they don't do enough. And that is what we have to call for.
Thank you, Otmar. I would say this was probably the perfect closing words, and I would leave it by that unless there are questions from the audience. I don't know if we have time to allow a few questions. I can see someone's raising it, and I think someone wanted to ask questions here. Please, if you could come to the front, there are mics on both sides. I think you could ask your question.
I have a very short question. What's the difference between a fireman, a soldier, and a physician? Why do you think that they have other obligations and commitments towards the society?
You know, number one, the soldier, this is a special case, and that is true for physicians as soldiers, as others, which are conscripted. And this conscription is being allowed by law, also by international law for those situations. That is okay. For firemen, it is the same thing as for a state-employed physician. If you are in an employment relationship, you have an obligation out of your contractual relationship. And that is correct, and that is okay. So if you are a civil servant, a physician, civil servant, if you are employed by the state, you may have a relationship with the state, a contractual relationship, which tells that you have to serve. And you have to serve this during a time of pandemic with or without emergency. You do so. Usually if you are a physician in an emergency ward, you are always dealing with the emergencies in there. So there is no difference to that. And there is no different obligation. The question is here, can a state tell another physician who has not an obligation, neither with a patient in danger at the situation or with the state, tell you will be conscribed to do the service for the state? And we say yes, this can be, a state can do that if it's been decided democratically by a state. They can call people to service, but only if this applies to everyone. The state cannot say, oh, you are nice people, you don't have to do anything for this pandemic, but you have to. That would be forced labor in my view. So, if there is a situation of emergency and the state wants to conscribe, then there has to be a balance in this, and the state has to take every measure to protect those who deliver this service there. And that is something that has not been foreseen in some of those acts which were planned for this. But when it comes to an already existing contractual relationship, this has to be served.
Thank you, Otmar. Any more questions? Yes, we have 3 more minutes, I think. So please be very brief and then a very quick answer.
Thank you very much. Like health systems that have the duty to universal care is a point to talk with this no obligation, no general obligation to physicians, and how to deal with this balance between these two necessities if we think about this necessity to care.
Good question. And I think here it points to the need of governments, of states, to prepare for this situation. What it means, in fact, is that if you want to have a universal health coverage situation, you have to bind the workforce contractually in order to be working for the universal health coverage. I mean, you cannot promise universal health coverage and have no obligations, have no relationship with physicians or nurses. You know, I mean, if you don't have a contractual relationship in one way or another, they will not provide this. So it is necessary for having such a system of universal health coverage to have a strict regimen of contracts between those who pay, for instance, the state and the physicians and the nurses, or social insurances which do this. and have a relationship with that. It is also foreseeable that you can do this in a completely private system. For instance, Switzerland has such a system, or the Netherlands, where everything is private, but nevertheless you have contractual relationships which then tell people what they have to do in case of. And this preparation has to be done, and has to be done sufficiently, and unfortunately in most countries that does not exist.
Thank you, Otmar. And you have one last question. Please be very brief. We only have 1 minute time left.
Thank you so much for this presentation. This is maybe more of a future conversation than something we could talk about in 1 minute, but I'm thinking about the AMA Code of Medical Ethics, which historically did have an obligation for physicians to respond in emergencies, but now no longer does, and how you see the legal and ethical context as reflecting perhaps a changing or an evolution in physicians' roles and responsibilities to society. Thanks.
Well, the obligation to help has been at least in the international deontology, always there for the case of emergency. And it has been always with the limit, and now this has been worded more strictly, with the limit not to endanger yourself. It is also only up to your competence what you can do. So I think that is pretty clear. What our demand is not that this has to be changed from an ethical or moral point. It has to be changed from preparatory and political point, so that the states who promise this, and in the international treaties they have promised this, that they live up to their promise and make it a reality that this can be done. And I think, like with the COVID pandemic, I really nearly have seen no case where people have said, I don't want to do this. You know, they have done this. And they have done this even in situations which were dreadful. Even some which have not received the vaccination when it was already available, and still have been working. And they have been all working day and night. So I think the need here is really for a better political preparation for this situation, and then we can cope with it. Thank you.
Thank you, Otmar. I know we are out of time, but if our two speakers allow one more question, then I would hand the floor over to you.
Thank you very much for your nice presentation. What I want to strengthen is if our function, bioethics, it's not to bring together, to work in those kind of situations, not only the medical association, I spoke as a medical doctor also, but to try to make conjoint work between laws, between politicians, that we will have from our place, that means from bioethics. Our aim is to try to bring them together to try to deal in special situations as disaster was, like I will present it now when you will finish, because I think that is very, very important to make a bridge between all those situations.
Yeah, Moti, absolutely correct. This week, this week, we have pledged to be part and to be included in the discussion of the pandemic treaty. Right now, we are only allowed to get some summary information, summary sessions. What we have together with other organizations have said, bring us into the room, challenge us for how to deal with the pandemic. We can help, and we can give advice from a medical perspective to do so. But so far, the nations are not willing to do that. They do this behind closed doors. And so far, it has not really brought a result.
Thank you to our esteemed speakers for their insightful presentations. We appreciate your contributions. You may now return to your seats.